everyone doing? I hope you're doing great. Just a couple housekeeping items. Please continue to use the Q&A and chat or raise your hand for questions. Wonderful, feeling refreshed. That sounds amazing. Thank you all for your participation so far. Again, if you're having any technical difficulties after lunch, Jennifer is still available for support. Here for a phone call, 269-220-0039. I know, I just want to say sometimes we just never know what's going to happen in life, and I hope everyone continues their best to stay safe. Take care of one another. Reach out to your friends and family if you haven't said hello in a while. So, sorry, to move on to the next part of our recipient meeting, our after lunch recipient meeting. It is my pleasure to introduce another provider highlight. Communities who received the PDO grant have worked diligently over the course of the last 5 years to provide their communities with training on overdose recognition and response, and to increase the availability of Narcan across their communities. 4 communities were awarded the PDO grant: Bernalillo County, Santa Fe County, Doña Ana County, and Rio Arriba County. We will hear from project coordinators from each county and from members of our state evaluation team. PDO program manager Rebecca Newdecker will be facilitating. Take it away, Rebecca.
Thanks, Tom.
You're welcome.
It's been my great pleasure to work with, support, and learn from the PDO partners over the last several years. As some of you know, the current PDO grant will be coming to an end at the end of this month, but we recently received the great news that New Mexico was awarded one of only 13 new PDO grants that will continue to support this important work in the years ahead. Our presenters today are going to talk about their programs over the last 5 years, but first, Liz and Lay from PIRE are going to walk us through the data related to this grant. Many of you know and or have worked with Liz and Lay from PIRE. They have been strong OSAP partners for a number of years. Dr. Liz Liliet Gonzalez is based in Albuquerque with PIRE Southwest and is a senior program evaluator with PIRE and the New Mexico-based co-principal investigator for statewide evaluation. She is also a local evaluator for many of our local prevention programs. A fun fact about Liz is that her early insights into responsible beverage service were gained while working in a South American bar which served beer in chamber pots with straws. Dr. Lei Zhang is a program evaluator with PIRE who's based out of North Carolina. She's our go-to person on data analysis and understanding what that data means for both the PDO and other grants. Something fun about Leia is that she did not realize how attractive she is to mosquitoes until she came to America. And with that, I'll turn it over to PIRE. Thank you.
Thanks, Rebecca, for your introduction. Okay, I think I'll go first. Can we see our slides? Okay, thank you. Again, so as Rebecca already mentioned, so our current project will end this on August the 30th. I think this is the perfect moment for us to look back and see how the program has achieved. With all these achievements, we can conclude our current project and turn a new page for the second round PDO project starting August the 31st. So a big shout out to all the program staff. We'll start a brief overview of PDO's major tasks. Next slide, please. So one of the major tasks of PDO is to provide trainings to diverse first responders, so including professional first responders and lay people or the community-based organization staff. Another major task is to distribute Narcan to the people who are trained. Next slide, please. So the overarching goal of this project is to reduce opioid-related overdose death. So to achieve this goal, we have 8 objectives, but today we are going to only talk about a few of them. So next, please. So the first one we're going to look at is the objective is to increase the Narcan distribution to make them widely available for the people who are at risk, and also made them available to their friends or family, their social networks. Also made this Narcan available, easily accessible to those community-based organizations, so could they serve their serve this community with high needs. Next slide, please. From this slide, you can see by the end of July, the project has distributed over 34,000 Narcan doses. So the trend has been increasing since the starting of the project, 2017 up to 2018, they maintained that level up till hit by COVID, obviously in 2020. But we still managed to, distribute over 60,000 doses. So with all those doses, where did they go? Next slide, please. Here you'll see, so the majority, 74%, went to lay people or the community-based organizations such as shelter or treatment providers. So this exactly the focus of the PDO project. We make this Narcan available to the lay people and to the organizations to serve the people with high needs. Next, please. From here, you can see we have already trained over 6,000 people, and obviously this in-person training were hit hard by COVID. And it's a sharp drop from the 2019 to 2020. And all the 2020 and 2021 numbers, they come from online trainings. Okay, next slide, please. Again, here you see the PDOs emphasize the focus. So the training participants, they are, the majority, they are lay people or, community organization staff. We also have professional first responders, but this training, the responder type shows our focus is consistent. Next slide, please. This one will tell you this project also emphasize the groups who experience the health disparities. So here we see the Hispanic, which is the yellow line here. So the level of self-identified Hispanic respondents in our training needs, this level is higher than the census level. And our LGBTQ group is the green line. This one is consistent with we have seen in our community survey. So pretty consistent from 2017 up to now. And the last group here is Native American group. This group is slightly lower than census level. I think that will be the focusing the next PDO project, to try to recruit more Native Americans into the PDO trainings. Next slide, please. So for this objective, so the PDO project tries to increase the general public awareness of the Good Samaritan law, but also to increase the use of the 911 call when an overdose happens. We don't have 911 call data. So today we're just going to talk about this awareness side. Next slide, please. This one is from our community survey. So we already have 4 years data now. So this one basically shows general public's understanding of this law. The lowest bar here is the group who says they know a lot about the law and can explain it. And the tallest bar here is the group who has never heard of it. It's pretty consistent. It's about like 45%. So the knowledgeable group is around 16 versus don't know about it is 45%. This is general public. So how did the PDO training participant do on this question? Next slide, please. So here you can see overwhelmingly they said after training, they learned a lot about the Good Samaritan law. I think those 2 slides show you the big contrast. So the PDO trainings provide details about the law and they have good discussion about the law. And I think it's effective way to educate general public about the law. Next slide, please. Okay, we'll go quick here. So this one is about this object, increased utilization of naloxone through Medicaid. We met this objective, so we'll just look at the slide quickly. Next slide, please. So here you see after the coal ARCS bill took effect in 2019, we see a big jump till end of 2019. So then dropped it in 2020. This is the Medicaid claims. Next slide, please. So the similar pattern we have seen here is Medicaid doses. We don't know about the pattern in 2021 yet, but for the 2020, we see the up and down. So we don't know the pattern in 2021. Okay, next slide, please. So we have talked about the Narcan. Okay, this is about reversal. So how did we do for this project? Next slide, please. So by the end of June, the project has reported 530 reversals. We believe we have underreported this because the form, the record of use form we use to collect Narcan use information, it's so hard to collect. That has been a challenge throughout the project. So we believe this number are underreported, but you still see the pattern from 2017 to 2020, this reversals has been increasing. So next slide, please. So this one shows you PDO counties and including PDO program and other programs. So all the programs reported over those reversal in 4 PDO counties and at state level. So the pattern is similar, increasing over time up to 2020. So far we have been talking about the reversals and Narcan distribution. So we haven't talked about the death yet. So what's the relationship among the 3? Next slide, please. So here it's a state level, death data, reversal, and Narcan distribution. I only have 2019 data for death, but just looking at the reversal and Narcan distribution, you can see there's tripled from 2017 to 2018, doubled. Then 2018 to 2019 was doubled. So there is definitely positive association between Narcan distribution increase and the increase of reversals reported. It's just 2 things, they go hand in hand. Had all this had all this reversal not happened, we will see a lot more death. So I think this is the ultimate story of the PDO program. By increasing Narcan distribution and providing Narcan training, we have slowed down overdose death. Yeah, this is for me. I'll pass it to Les. She is going to share her thoughts about the interviews we conducted for the project.
Thank you, Lei. It's ironic that when we're looking at death data that we can have a positive message coming out of it, but it definitely shows how important the work that you were doing is. Can we have the next slide? We conducted interviews as part of this with the hub site coordinators as part of this project. And our first interviews were done during the mid-pandemic shutdown. So we were able to get some good insights about how the pandemic was affecting folks, as well as follow-up interviews that were done this year. Definitely because as we were attending meetings regarding the work that you were doing, there was a lot of troubleshooting that was going on and kind of changing up of the trajectory of your work. So we wanted to be able to capture that. I will have to be very fast because I want everybody else to have an opportunity to speak, and you can definitely speak to these successes and challenges. But some of the things that we found very interesting were that each county had a very different context, and you were all set about going about building the infrastructure to distribute naloxone and provide overdose education in different communities. But it's just interesting in the fact that in a place like New Mexico, that we had such diverse approaches to meeting local needs, which reads to me that there's a strong attention to local culture, local relationships, and knowledge of infrastructure and structural relationships. You all developed some very innovative strategies to address stigma in trainings, and we saw these kind of evolve over time, as we also saw observations about how stigma was gradually kind of decreasing among different populations. So there would be, for example, some of the ways that people would do this in trainings is that, trying to meet people where they were at. So for example, in some trainings, you would not bring up illicit drug use, kind of depending upon the audience, for fear of kind of alienating them, or not being combative with what we call haters, so people who would be difficult to work with. Hats off to you coordinators who were able to do trainings in a way that would address people respectfully and honorably and answer their questions. You often spoke about, you gave stories, you would bring it home. So you would tell stories about the abuela that had accidentally had an overdose by mixing their medications or using a different medication. You would provide data about prescription opioids and how prescription opioids would also lead to overdoses in order to kind of bring it home once again that everybody who is at risk who uses opioids. You would practice and train people on destigmatizing language. And and talk about Narcan as being sort of like a first aid kit. It should be part of everybody's first aid kit. Or the fire extinguisher analogy. And so one of the observations that we've had is that changing stigma is very slow. For example, you often spoke about how law enforcement stigma definitely took time, but you did see some small successes happening there. So, and especially in communities like Rio Arriba, that can be very hard because there's deep trauma in those communities in relation to in most of our communities, there's a lot of trauma in relation to police enforcement. So, working with the community and law enforcement in order to destigmatize Narcan and overdose prevention has been a slow process, but you started to see how law enforcement would call out to you and reach out to you in order to help with harm reduction efforts. And then also just kind of what we're thinking about is how changing practice, like carrying Narcan and learning and promoting overdose prevention, can change values over time. So you're not going to change stigma by giving somebody, a shameful lesson on how they're stigmatizing. But in the practice of carrying Narcan, in the practice of talking about Narcan, in the practice of talking about the risks of overdose, people are observing gradual changes. Next slide. So I can lead it to the next person. There were many challenges and opportunities. One of the reasons why we focused on the qualitative component was because the data collection, as Lei mentioned, was so difficult. The record of use forms were difficult to collect. For those of you who may remember at the beginning of the grant, we were actually expected to collect demographic data from people who experience reversals. So if you can imagine just kind of walking that through, somebody has a reversal and they wake up and you ask them, can you tell me what your gender, date of birth, your race, and your sexual orientation are? So those were definite challenges that we had to overcome. But then again, as you institutionalized this process and as the trainings became more institutionalized, you were able to incorporate these trainings and the data collection into the work and collect some of this very important data in relation to disparities. I was really impressed with the slide that Lei was able to produce, and that was for people who were trained. But it was great to see that we're able to reach, we are reaching the populations that we're trying to reach, that we need to reach. And we definitely saw a shift. And if you see that slide later, we saw an increase in the Spanish language in the Latino population, perhaps as a result of our being able to incorporate Spanish language trainings in the process. So there's a desire to have one data collection system across the state. You all are nimble challengers of a multi-tiered system of tracking and acquiring and documenting and distributing Narcan. And so there's definitely a hope to have one system so that we can have a coordinated process to be able to get the Narcan out to where it needs to go and also to document that. There was, and then, well, I guess the last piece is that while the pandemic challenged outreach, and we definitely saw that in the beginning, and I was kind of grateful that we had this opportunity like mid-pandemic shutdown versus kind of post-pandemic, not post-pandemic, but while we're opening up again. Some of you coordinators were able to do Narcan training and distribution virtually. And that made for much easier data collection. It made for the trainings to happen faster and more easily. However, of course, being on a line hampered your ability to reach some hard to reach people, like Spanish speakers online, for example. So kudos to you, and I will especially onward and forward as we address these challenges with the next grant. Next speaker.
Thank you. Next up are our program coordinators, and we're going to start with Nai Walter. Nai is the Substance Use Prevention Coordinator with Doña Ana County Health and Human Services. Her work concentrates on reducing overdose-related deaths and preventing risky polysubstance use among adults in the community. She works with and trains first responders, professional first responders, and key community members on preventing opioid overdose deaths and implementing community-based strategies such as purchasing and distributing naloxone. She provides these trainings in both English and Spanish and is also a certified harm reduction specialist with the state of New Mexico. She holds a Bachelor of Public Health, which she received from NMSU and graduated with honors. And she's currently pursuing a master's, she's a graduate student in public health and with a concentration in health management, administration, and policy at NMSU. In addition to all of that, she's also working towards a certified health education specialist, CHES, and prevention specialist certification. And with that, I will turn it over to Nai to talk about Doña Ana County.
Hi, everybody. I'm trying to share. Okay, can you see my screen? Yes, I think it's the wrong one. Which one can you see? Sorry, I'm sharing the wrong screen. Okay, let's see if this works. It's right. Okay, sorry. Okay, hi everybody. My name is Nai Walter, and I'm the Overdose Prevention Coordinator for Doña Ana County. As you heard from all the data and everything, it's been a great grant. We've done a lot of work. We've been able to provide Narcan to the community, and it's been a long journey, and I'm really, really happy that we are actually going to have it for another 5 years. This work isn't done, and it's really cool that we can continue doing this. When we started in 2017, from the beginning, we needed to get this grant going and into the community, getting it to first responders across the county, getting them trained and equipped with Narcan. Acceptance of Narcan was a big issue, like you heard. There was a lot of pushback from some responders, especially law enforcement. A lot of people have, biased. It was a huge thing. I noticed when doing trainings that a lot of people had the idea of the word overdose is a huge thing, so a lot of people associate that with something that like people doing heroin, or that only happens with illicit drug use, people using substances, people that are using on the street. It's not, you don't relate an overdose with a medication or something that is given to you by your physician. So through doing these trainings and providing education to the community, especially to first responders, through the years, it's been slow. We were able to educate people and teach them, this is going on. This is from prescription medications as well, mixing substances. So, it's been a long journey to now, but we're getting there. And like you heard, Narcan is actually now accepted. I have great conversation with law enforcement. They come and pick it up from me. We are still trying to see if they can actually leave it behind when they assist somebody with an overdose, which is that would be like the next step. It's also really important to talk about stigma and try to change this slowly, but it is changing, and it's slow, but it's going to happen. So since 2017 to 2021, we have trained 2,218 people and counting. We provide weekly or biweekly overdose prevention education and naloxone trainings to the community. And we do this in person as well as through Zoom. We have distributed 4,710 Narcan kits, also counting. Every person that gets trained receives a Narcan kit, and the agencies that we have trained as well, they can come and pick up Narcan. We have a great relationship with a lot of the agencies around here, and there's one that I really love, the La Clínica de Familia. They train every single employee that comes in. It doesn't matter what your position is, everybody gets trained in how to use Narcan, and they all receive a Narcan kit as well. Through the grant, we actually built a great coalition, and it is called the Opioid 360. And we meet monthly, and we have key stakeholders from the county in attendance every month, such as harm reduction sites, emergency room directors or staff, Medicaid-assisted treatment providers, health centers, Department of Health, mental health providers, and many more. I believe that there's like 170 people on our listserv. Not everybody attends every month, but information is sent out to everybody, and we keep communication going with all of them on a regular basis. Let me see what else. We work with, we have trained 26 train the trainers, which 9 of them have received their fidelity check. We also, through our collaborations, we receive data from Mesilla Valley Regional Dispatch, which is the 911 overdose calls. And collaboration is key. Through the Opioid 360 and our other coalitions that we attend and community members, we've been able to collaborate and try to get information from all these agencies. So we normally receive a data sheet, and he calls it a heat map, and it shows on every month how many people have overdosed and called 911. And through the months, I asked this person if they could add a little bit more information, or if he knew where I could get more information for our purposes, just to see who's overdosing, what is the age group. I asked him if Narcan was provided, if the person was revived, if they were transported to the hospital. And he was really cool. He added all this information. He does have it, so he added it to the spreadsheet. So now we get it once a month with all this information, and it's really important so we can get Narcan to the community. We can see where it's happening around Las Cruces. Another really important thing is we also work with NMSU College of Public Health, and we have 1 to 2 interns per semester. The interns create monthly flyers where we schedule the trainings and distribute to our Opioid 360 group, NMSU listserv, HHS staff, Doñana County media. They publish it in the free newspapers. They also publish it in social media. Collaboration is key. It is very important that you take advantage of the listservs from other coalitions as well. All that information goes to everybody. Because we've been doing this, my flyer goes out all throughout the state of New Mexico. I've had people from all over attend the Narcan trainings, and it's really cool because we can connect them with their providers in their own county. On the flyer, we provide the links so people can click on the link and sign up for the training. I also created a QR code where people can just scan the QR code and sign up for the training. All this is online through Zoom, and I've tried to make it as easy as I can for everybody. And it's really important that you're able to utilize and collaborate with other providers here. Now, through COVID-19, it was really cool because it actually stopped us from being able to provide trainings in person, but it opened up this other world of Zoom. So it was really cool being able to still provide the trainings to the community, and it was really easy for everybody to be able to attend the trainings and not be exposed. It was a safe way for people to attend these trainings. I've had 6 interns. Also, the internships continued. Everything's virtual. I work with NMSU, so take advantage of the university, work with the interns. They're very eager to work. They learn a lot. They provide all these trainings. The intern that I have right now, she's already trained about 70 people, and she does a training every week or every other week. And every time that there's an agency that needs a training, she will provide that training for me. So they're a great resource. And I also always have one that speaks English and one that can provide a training in Spanish. So we can provide these trainings to the community in both languages. We've actually trained about 500 or over 500 people since COVID started, and this is all virtual. Distribution of Narcan was pretty tough through COVID. People did not want to come in and get their Narcan, but I would meet people in a parking lot, and I would put the Narcan on the hood of my car, and they could come and pick it up without even having to talk to each other. They just gave me their name. I knew that they had taken the training, and they could get their Narcan kit. So, just be very innovative and try to work with what you've got. So it was slow, but we were still able to get Narcan to our community members, and as well as the agencies. It was just dropping off whenever they needed. They would just call me and I would drop it off to their facilities. Communication and collaboration is super important. I can't stress this enough. It's what got us through COVID, being able to provide the trainings online and just collaborating with each other or working with each other through other agencies, where you help them, they help you. And just, this is for the community, being able to provide the services that we are providing to everybody that needs it. Online data collection, this was amazing. Working with Pyre, Lay made my life so easy. Data collection went all online. She created a tiny URL for me, and it was the easiest thing to do, being able to just share the link and everybody would just click. I could see it live. I would, I have people do the training, and then we stop before we end the training, and I can see who has filled out the survey, and then I can thank them, and then they're done. And if they need a certificate of completion, I also provided that for them. But the online data worked. It was excellent. I think I probably, from those 500 people, I probably got 2 or 3 that didn't fill out the paperwork. And that's amazing. You get way more if you're in person that don't want to fill out the paperwork. I also work really close with the National Latino Behavioral Health Association. I've trained their trainers, and they provide trainings as well all over New Mexico. And when they're in the different counties, they also collect data for us, and I provide the Narcan to them for the people that attended from Doña Ana County. And connecting people with the different PDO grantees through Zoom, we were able to do these trainings all over. And a lot of people reached out. They wanted trainings, and they were in Albuquerque or Santa Fe or Roswell. So I was able to make these connections with their providers and start collaboration with them as well. I think that's it. The most important thing is, like I said, make sure that you collaborate. That's the way you're going to get this done. And interns, I swear, just take advantage. It's the best work that you'll get. And they're just awesome. I really love the interns, and I don't think I could have done all this work without them.
Thank you, Nai.
Thank you.
Our next presenter is going to be Alicia Martinez with the Mountain Center, and she's the Harm Reduction Specialist, PDO Coordinator, and Overdose Prevention Trainer for both of our Mountain Center counties. There's Rio Arriba and Santa Fe. She served as a bridge across initiatives at the Mountain Center, and she's worked at the Mountain Center for 4.5 years in community outreach positions, including peer support for the Healthy Transitions program that focuses on youth ages 16 to 26, as a harm reduction specialist, and also providing auricular, I hope I'm saying that right, acupuncture specifically to treat addiction. Alicia was born and raised in Espanola and graduated from Northern New Mexico College, majoring in psychology. Her ultimate goal is to serve her community, helping youth and adults who deal with substance use disorders and offering resources that she didn't have access to. A fun fact about Alicia is that she plays guitar and likes to paint. We look forward to hearing about your work in Santa Fe and Arriba counties. Thank you, Alicia.
Thank you, Rebecca, for the introduction. I appreciate you all. I'm going to share my screen. Everyone can see that okay?
Yes.
Well, thank you guys. Thank you all for being here. I'm happy to be here. I'm happy to represent, the Mountain Center on the PDO grant. Thank you for all of your presentations. It really does show, the hard work that's gone into our programs. For the past 2 years, I'd just like to say that, we, as the Mountain Center, we adopted this grant in 2019 from the Prevention Alliance in Santa Fe. So yeah, for the past 2 years, we've been able to work really closely with our, local law enforcement because of our, harm reduction program in Rio Arriba County. They could come pick it up from us, or, we've been meeting them in the parking lot. Another really important partner, is our EMT and fire department, because they're always the first on the scene, when something happens. And so they're able to, give that Narcan out to those people, who have, recently had an overdose. Working with a LEAD program, and, the offenders that they're, working with, we're able to, train them, give out education on street drugs, which has, helped identify, what are opioids, what are, fake pills that are, circling around our community. With the Mountain Center, we do provide, fentanyl test strips for people in the community and for, our clients. They could identify, what, is in their drug of choice. And then, just collaborating, like Nai said, helping each other out because, it's better to work together, than against each other. Some of the highlights that I like to, point out, during our time with, the PDO grant, we were able to get connected to our local high school, our colleges, really focusing on, the adults 18 and older, again, to educate them on, the effects of drug use, mixing alcohol, or, what stigma barriers, that are affecting our community from getting help, for reaching out, like, language barriers, words to avoid. Although we could not, give out Narcan through the PDO grant at the Mountain Center, we were at least able to use our SOR grant to do so, and, at least get them resources within the Mountain Center. Resources that the Mountain Center provides are counseling services, case management, MAT, just trying to, help our, younger adults who are, suffering from, stigma. And there on the top left, me and my coworker were at the Espino Valley High School. We're just advocating for, educating them on what we have to offer. And then on the bottom left and right, at the Northern Community College, hosting events, advertising for, Narcan. One of the best parts of this job for me was being able to go out in person and really, host, events for, our people. Behavioral Health Day, we were there at the Buffalo Thunder Resort. We did a culture of healing for the Pueblo of Poake, the Poe Museum. The Rally for Recovery at the Santa Fe Community College. Was able to actually get connected to our local radio station here in Espanola, Quedice. So, talking about, Narcan, advocating for the Mountain Center and what we have. Through the Mountain Center, we have our harm reduction program, which allowed, PDO for me to go and do street outreach for, our rural communities who don't have access to internet or phones. Any way we could reach our communities, we were there, giving it our all. We gave out Narcan, flyers, pamphlets. We taught the importance of, rescue breathing, educating our communities on, again, what we have to offer, our MAT program for, people in recovery and for people, struggling with recovery. I was able to, share my personal lived experiences in harm reduction, which ultimately helped break the ice for those people who are afraid to ask for help. So I thought it was really, fun being able to get out into our communities and showing them that this isn't just for drug use. This is a first aid. It could be, used for accidental overdoses, for kids who are experimenting with taking certain substances, going to parties. I've even heard of just people experiencing it with their animals. It could happen anywhere. You could be at the wrong place at the right time, and you ultimately save somebody, because you go to these events and you give trainings, and you have people who just don't understand. They think that it's enabling, or we're not helping the situation. But as an advocate and as a person who believes in Narcan, I was able to showcase that and change their minds about what they were hearing. And then COVID happened. So adapt. During this pandemic, we had a lot of ups and downs. We had to figure out ways to reach our communities, especially our rural communities, which had a big effect on getting help, because you need a computer, you need a phone, you need internet. So we at least had our Zoom online trainings. We utilized parking lot drop-offs. We even mailed people Narcan, making our virtual flyers. As you could see below, my colleague and I were just kind of coming up with ways to get people's attention. We did also use QR codes, which was new, and using my own social media to reach my peers, my family and friends. Although our organizations and businesses shut down, we still managed to reach people from not only all over the state, but even other states were able to join, which ultimately made it easier for people to attend. So yeah, again, using online Zoom for trainings, it allowed people who were uncomfortable to ask a question, because they were able to utilize the comment box, so they didn't felt that pressure taken off of them. Or if they wanted to be anonymous, because like I said, I'm reaching rural areas where people have that stigma. So they were able to turn off their cameras if they wanted to be anonymous. So a lot of good came out of this pandemic. It allowed more people to get connected from other states, which normally would be harder because of funds for travel and such. It was less expensive, and then again, we're not having to haul around projectors and computers and utilizing that. So yeah, it definitely saved us money, time, and energy. We were able to connect a lot more to our rural communities. Here we have a little bit of data. So again, we've only been in this grant for 2 years. So in year 19, when we first started, basically starting from scratch, we saw 202 individuals. They participated in 25 overdose prevention trainings and received 386 naloxone kits for personal use, or if they wanted to distribute it to their clients. Our partner agencies actually reported 40 successful overdose reversals, which were provided 470 replacement kits. So that's year one of us just starting out from scratch, trying to learn how to present and who our partners were going to be utilizing. And then in year 20, when a lot of things shut down, it got hard for us, but we adapted using the online. So as you could see, the number of individuals that participated went up. So 257 participated. and 43 overdose prevention trainings and received 610 naloxone kits for, again, personal use, or if they wanted to, distribute it to their clients. Our partner agencies reported 123 successful overdose reversals. That's pretty big. We saved 123 people. And, they were provided 84 replacement kits. So, for 2 years being in this grant, we had to learn, about the grant, not only about the grant, but how to adapt, during COVID. So I felt like, that was a big success for us as the Mountain Center. And on as you could see, I have, total number of people trained using PDO funds by community. Rio Arriba is in the gray and Santa Fe County is in the yellow. So, we had those two counties. And as you could see, the training distribution shows you the percentages, 10%, 10.7% in Rio Arriba, and 16.3% in Santa Fe. And then the distribution of nasal Narcan kits by PDO funded community, again, 20.2% in Santa Fe and 7.6% in Rio Arriba. Rio Arriba, New Mexico used to be #1 for the most drug overdose rate. Now we're at 17, and it's not to say that the drugs aren't there. It's just that the education piece from the Mountain Center and all of these other grants that you guys are working on, has proved to show that we've gotten better at educating our youth, the adults, and the people in our community who didn't have that growing up. So kudos to all you guys out there. Closing, we're able to reach, many people within the 2 years. Again, we adopted it in 2019. We were able to work with our nonprofits. I'd like to just give a shout out to Barrios Unidos, Lupe. She's been a huge supporter of the Mountain Center. OPRI, just shout out to them. They've helped us advertise many trainings, providing CEUs. Our local high schools and colleges. We just recently partnered up with the New Mexico Corrections Department, which is pretty huge. We're going to be providing trainings for not only their staff, but the offenders that are there. Working with our local law enforcement through harm reduction, our recovery centers. These are just a few of our accomplishments within the 2 years that I've been here. I feel very honored to serve the community where I grew up in, and I'm happy that I could continue to do more. So thank you all for listening to me, and I appreciate all you guys.
Thank you very much, Alicia, and we really do appreciate the experience that you and Phil bring to this work and the commitment. So thank you. Our final presenter is Pelatia Trujillo, and I have an introduction that I think I'm going to largely skip, except to say that Pelatia has a business background that she's brought to community organizing and has a real commitment to giving voice to the community and helping people. In addition to being the overdose coordinator, she's also the executive director of Dedicated Outreach and Prevention Education Services. And I think with that, I'll stop so that we can listen to Pelatia. Thank you so much. I think you might be muted, Pelatia.
I think you might need, if you're on your phone, I think you push *86, I think, to return or turn your mute off. I think that's what you push. If Jesse or Jennifer can confirm how you unmute if you're on a phone.
Hey,
Oh,
do you hear me now?
go. Yes.
Hey, thank you. So I was actually just looking for a time check from you, if that's cool. Did you want me to end at a specific time so I can party?
Yeah, can maybe about 11:05. Let's just do that.
All right. All right, perfect. Thank you, Antone. So thank you for that introduction. I'm going to go ahead and share my screen now. Now, these ladies put me to shame, though. Their presentations were very good, but I got something little. So, can everyone see my screen?
Yes. Yes.
Awesome. Thank you so much. So, like I was introduced, my name is Bella Dia Trujillo. I do have an MBA background. So when I did go to college, I went to UNM and I was focused on business. But moving through that, I kind of became an activist at UNM, like most of us do, right? And came into the harm reduction realm. It was more specific to my kind of history and background in the community. And so I'm excited to be a part of the harm reduction world, and I'm excited to see how it's expanding across Bernalillo County. So just moving on for the sake of time, I chose to focus my presentation on just some kind of outlooks that I have from our actual programming throughout the 5 years that we've been with PDO. I've been with the Health Equity Council, formerly known as Bernalillo County Community Health Council, since July 2018. And so I'm excited to see how the grant has grown, and I'm also excited to see what's going to happen in the future. So I'll start with actually shout outs to everyone. So to all the other PDO providers, you guys kick ass, and I'm so glad that I got to work with you guys, and I'm so glad you did so well making this happen, and I'm excited to move forward with you all. And then also to Coop and Pyre, OSAP provides some really good supportive networks, and we couldn't have made all this happen without having them available at our disposal. So once again, thank you all for your help in getting this done, and I'm excited to party with PDO in the next 5 years. So let's go ahead and move ahead. Just want to kind of touch on harm reduction and how it's allowed us to navigate and move through the overdose prevention distribution that we've done, but also how it's been helpful and how can it be helpful in the future. So first, when we're talking about harm reduction, I am lucky enough to work at an organization that focuses specifically on public health, but not only focuses on public health, implements the harm reduction approach to many different types of public health. So when we talk about harm reduction, we're not necessarily just talking about substance use. At the Health Equity Council, we try to take a harm reduction approach to all barriers to access to health resources. And so that's made it, well, one, very easy for us to navigate and network through resources, but also to build on identifying that unmet need that we might not otherwise connect with other community resources. Collaborations and partnerships. So in the harm reduction world, as you know, it can be tough to build those networks and sustain them, right? And so the way harm reduction has helped us is through those collaborations and partnerships that we formed through some of our programs that we already have at the Health Equity Council. We were actually able to start off with like a running start. Two of those programs that I'm going to name specifically is one, the Opioid Accountability Initiative. So Christine touched base on what OAI is a little bit earlier, but just as a refresher, the Opioid Accountability Initiative is a collective of community members in Bernalillo County that wanted to specifically focus on opioid accountability, and not just opioid accountability in general, treatment, harm reduction, and prevention when we're talking about opioids. And so obviously we all kind of function, the harm reduction, treatment, and strategy groups, not obviously all, but we all function under that umbrella. And so OAI, when I came into this and when we started this grant process, was already up and rolling, which kind of brought us a lot of networking advantages. That means getting information out and connecting with other service providers or community members that could be helpful in the distribution process. But also there was a large amount of knowledge and experience that we were able to go to and talking about past experiences in this ever-changing harm reduction world. And so that kind of gave us a jump start as well. And using those networks has made it really easy to function. The harm reduction strategy group, moving into community engagement, is formed of a lot of organizations and community members that are also focused on not only overdose prevention, but harm reduction in general. And a lot of those programs are a lot of the people that are involved with that are actually community service workers that are actually out in the community, providing outreach to communities across Bernalillo County, right? And so like I said, again, sometimes it's hard to build a harm reduction, or it's always hard to build a harm reduction network that's sustainable and continuous, but it's even more difficult to build those sustainable relationships, those trustworthy relationships with community members, so that you can have those hard talks about overdose prevention, harm reduction, and what other public health needs might need to be assessed, right? And so the good thing about having the harm reduction strategy group is we had a whole bunch of harm reductionists that were out working with the community that already had connections and relationships built, which kind of boosted our word of mouth stuff. And in the harm reduction world, word of mouth can, be your best marketing strategy, right? And so a lot of those networks that we formed through the harm reduction strategy group allow us to focus on not only overdose prevention, but harm reduction resources and services across the state, available to community members, but also available to other community service workers so that they can provide resources, valid, trustworthy resources to community members when they're out there providing services. So now it's time to talk a little bit about how our strategies evolved over time in the PDO program at the Health Equity Council. So initially when we came, and I already see a spell check error. My bad, everybody. That's supposed to say hub and spoke versus direct outreach. So I apologize about that. So initially when we started the PDO program, our primary focus was going to be on a hub and spoke model, which is basically where we connect with different distribution networks that are already trusted in the community. We provide a TOT training, and then they go on and provide Narcan and services to those networks that they've already built and formed. We've connected with 15 consistent distribution partners over this amount of time. And some of those are really big entities that we've been working on getting Narcan in for a long time. So a perfect example of that is like the Metropolitan Detention Center. Getting Narcan distributed from MDC has been an ongoing kind of harm reduction goal, I think, for a lot of individuals, and that included like Department of Health way back when I was working with like Albuquerque Healthcare for the Homeless. We were still consistently working on making sure there was a constant source of Narcan coming through MDC when people were released. And so MDC is a perfect example of one of those organizations or programs or targeted distribution sites that we want to make sure that Narcan is coming out of. Although the hub and spoke model has been super, super effective, and since those relationships have already been created, it's a lot less work on our end, right? Because those communities have already built those relationships. So that's actually made it very easy to distribute Narcan to different community members, especially ones that don't necessarily have the trust in them to find new resources. They want to continue with the same resources they've already had. But it's also been better to take a more direct outreach approach. And when I say direct, is just getting our supplies going out into the community at non-traditional times, non-traditional locations, and really connecting with community members and having those hard conversations, right? And so throughout the process, we kind of recognized that firsthand outreach was not only giving us that access for those relationships, but it was also giving us opportunities to connect with other distribution networks that we may not have looked at prior to that, right? And so building those relationships and making that happen has given us more direct outreach opportunities. Not only have we been able to go to like public health events, we've also been able to do like pop-up events where we just go somewhere, pop up a tent and give out Narcan to whatever community is available. We've been able to collaborate with other outreach teams and go out with them and provide Narcan as well directly to the community. But also we've utilized those approaches to also give opportunities to incentivize community members to provide feedback to us about some of the resources, of the harm reduction resources in Bernalillo County. So we've also used that kind of direct outreach approach to actually ask community members questions about some of the unmet needs they might be experiencing from the harm reduction programs. So it has been super helpful to combine both of them. And as both Nai, or as both the ladies were saying, it is very, very good to keep those collaborations open. And that's not just substance use specific collaborations, right? If you'll notice, if you're assessing someone's maybe unmet need and you're trying to figure out their risk, sometimes when you're having conversations about different harms that they're experiencing, then other opportunities to provide resources come up. And I've seen that a lot with Narcan and PDO, where I've been engaging about either needle pickup or community outreaches or events, and it's connected us with someone who needed overdose prevention and wasn't able to get that. So also, a huge one is identifying risks. Now, and when I say identifying risks, we recognize as community service providers that the risk is there, but a lot of community members may not know that they're at risk. And so as we've moved on through this process, we've tried to make sure that we can connect with community members in a way that they can recognize that risk without using your standard scare tactic-y kind of jargon approach, right? And so some of the outlets that we've used to do that is obviously through the harm reduction strategy group by sending information to individuals, not only on that listserv, but connecting to people on other social media outlets, but also the way we connect with people on those social media outlets, right? Like, are we providing resources when we're having these, providing this information? Is there resources on there? Are there connections to be made? And what's the best way for them to gain access if somebody comes into contact with some of our marketing materials, right? We've worked with a lot of, we've worked with other providers under that OAI umbrella. Like, I work closely with Christine. Shout out to Christine, loved your presentation, girl. We work closely to actually connect with community members that aren't traditional to PDO. And so when I say that, I'm saying 18 and younger participants. So even though our 18 and younger participants can't get Narcan specifically through us, OSAP did make it accessible for us to be able to like hit up Bernie if we needed some Narcan for some use, but also it connected us to parents, teachers, and other lay people that are in the lives of youth. And so having those connections with youth, even though we're not distributing directly, allowed us to connect with other lay people connected with those youth. Not only that, but it also allows us to provide Narcan or get information, but also provide organization or provide Narcan to those organizational entities that they're spending the most time at. So a perfect example of that would be Albuquerque Public Schools, right? We had security guards that were experiencing overdose while they were doing their regular parameter checks and whatnot, and they needed Narcan to be able to, you know, respond in those kind of situations. And so obviously we're not distributing to APS where we're giving it to students, right? But we're giving it to security officers, we're giving it to teachers, we're giving it to parents so that they can, you know, make sure they have that access. Let me double check my time. Oh, I'm already going over. I'm so sorry.
Time's up.
And so just some less, yeah, my time's up. Should I stop? So I'll just go through this really, really quickly. So lessons and learn, just like everybody spoke on today, stigma is going to be a continuous conversation. And so moving forward, as we go through these next 5 years, we want to make sure that we're revamping and touching base on our materials so that not only those stigmas are being identified, but they're also culturally specific, and we can go out and actually make a difference in identifying that risk, no matter what the stigma is and what community members you're focusing on. Program sustainability, once again, even though we focus on sustainability through the PDO program, when we came to the end, we still wanted it to be a little bit stronger. So moving forward, I definitely want to focus on strategic planning and sustainability at the beginning so that we can make sure when we get there, we have something a little more solid. And then remember, when you're doing outreach, don't be afraid to look into those non-traditional avenues, right? There are plenty of community outreach opportunities out there. And even though they don't conform to like a substance use event, get out there anyway, because people, like I said, assessing that risk, once you have that conversation, it can change that need really quickly. And then having the harm conversations. This is harm reduction. We go hard and we go real. So when you're out there talking to community members, make sure that you hold that space for people to be real and open about what they're really going through in this substance use period of their life. But also like recognizing that harm reduction approach while you're having that conversation, that non-judgmental, that dignity, supportive, and reducing harm is the primary goal when you're having these communications. And then also, finally, I'll say cultural awareness is huge, right? We have a lot of our tribal communities. We have Spanish-speaking community members, and we also have individuals that may be dealing with situations with their citizenship as well that oftentimes are difficult to get to. And so we want to promote that cultural awareness in our training so that we can reach those avenues a lot more successfully. And so I'll end with that because I talked too much. You knew I was going to go over, Tone. I'm so sorry. I appreciate you all for giving some time and sharing some information, and I will pass it back on to Tone.
Thank you, Pelatia. Oh, it was wonderful to hear your voice, and thank you for your presentation.
Yes.
And I want to thank all the PDO presenters. It was wonderful. I mean, I'm blown away by all the work that is happening in the PDO communities, you know, just out in the prevention world in general. It's amazing. I'm so grateful to work with prevention. And I want us to continue to move forward in that, and especially looking at harm reduction. And I like the explanations. I love how you're bringing it to the communities where they're at, and that's what we need to do. And so I definitely appreciate your thoughts around that. So I do want to mention, I was going to do a poll, but I'm not going to. But I do want to mention, if you have not received training in opioid overdose recognition and response, and you are interested in doing so, please contact any of our PDO presenters and also our state overdose prevention coordinator, Bernie Living. We will put his address in the chat. And I know Rebecca also wanted to do a little bit of a closing, but I believe she'll put something in the chat. Our next presenter, I'm gonna keep going on. Our next presenter, oh, I wanna mention to you real quick, we'll probably cut our break a little bit short just so we can kind of try to wrap up, hopefully a little bit on time as much as possible. Thank you. Our next presenter has been a longtime colleague at the OSAP, Office of Substance Abuse Prevention, Heather Burnham. Heather comes from a military family, initially abroad and then growing up mostly in Tucson, Arizona, before heading back east to attend Smith College for a double major in psychology and neuroscience. She has a master's in public health with a focus on community health education and an interdepartmental minor in drug and alcohol counseling from New Mexico State University. She is a certified health education specialist and a certified prevention specialist. Woo! All right, Heather is going to be walking us through questions and tips on the OSAP billing system through BHSD STAR. Heather, over to you. Thank you.
Thank you so much. Sorry for that bit of a delay. Give me just a second. Okay, perfect. So I want to try and be respectful of time, so I'm just going to dive in. Fully appreciating that talking about billing, there's a wide variety of skills and abilities, to people who are absolutely petrified to people who could do this stuff in their sleep. And hopefully the people who are petrified, I'm happy to work with you, to hold your hand if you need be. And if you can do this in your sleep, hopefully there'll be something here that will acclimate you a little bit more to how our office functions. So first I need to start with the mission of my agency. My state agency the mission is to transform lives. Working with our partners, we design and deliver innovative, high quality health and human services that improve the security and promote the independence for New Mexicans in their communities. The 4 goals to try and do that include things like helping New Mexicans, making access easier. If there's a way that we can do that, please, again, reach out and let us know. Because we always want to be improving. These are the goals, of course. We want to be able to communicate effectively, which I hope that today you've already been experiencing. And we want to support each other. And that's part of what my goal is. Hopefully I'll communicate effectively and be able to support you all as we enter the realm of billing. There was a bunch of stuff I wanted to cover, and most of it is pretty basic, but I haven't covered it in a while. So if you've been here in the last, I'd say 3 to 4 years, this should all look really super familiar. And if you haven't been around that long, hopefully this is also pretty familiar. So I'm going to cover fraud, waste, and abuse, and even contractual items, some STAR-related things, how to document costs, and some general principles. So the fraud, waste, or abuse. I was really struck looking at the notice of grant award for the PFS 20s because it really emphasized the responsibility that getting all of this money from the feds entails, that we must demonstrate that we are good stewards, particularly that we're avoiding fraud or just waste or abuse of any kind. Most of OSAP activity comes from federal grants, and that's public dollars. That's your taxpayer dollars coming back to the community. So part of that notice of grant award, I'm going to try and avoid the acronyms, is that there is a financial advisory service within SAMHSA that can do an administrative review of our financial management system, ensuring, of course, that we are doing appropriate oversight of your financial system. So that's the long and the short of part of the reason of why we do what we do. And these principles should help keep you above board and demonstrating your good stewardship, just as it would for us. And if you don't already know and you're new to our system, we have an annual audit requirement that is usually submitted at the end of the state fiscal year. It's okay if your audit is actually done on a calendar year. It's just submitting to us and to our Behavioral Health Services Division financial area, that sending them your audit as well. Similarly, keeping up to date on staff changes is really important. And similarly, that as people join or move on in their lives, that each person uses their own STAR account, that you're not logging into somebody else's account that tags a name that's not yours as the activity that's happening in STAR. Because I'll get to that in a second. Sorry, I'm a little all over the place. So how do you determine your costs? It's really important that you stick to your scope of work, that you are not incurring costs and then billing us for things that are not associated with your scope of work. So one of the ways to determine costs is to look at your scope of work and be able to assign costs to the various things in your scope of work. That, of course, changes a little depending on what your organization's fiscal policies are, but there are general principles. Again, must be related to your scope of work. So you have to determine what you're billing for and how it relates to your scope of work. And STAR, of course, for those of you who have the fortune of knowing how to enter things in STAR in its own language, you have to dictate what you're doing and how it relates to your scope of work. Similarly, I know we've heard a lot of really awesome things about Narcan trainings, but SAPT providers, you do primary prevention. You do prevention that happens before there's a diagnosis, meaning it's great that you want to help support Narcan trainings, but that's not primary prevention. That's not technically part of your scope of work. And while, of course, there's a major opioid epidemic and it's absolutely important, and we're really it's really awesome that you're there and you're providing some support, do recognize that is starting to have a bit of mission creep away from what your specific scope of work is about. So general principles: identify costs of all of that are associated with the time, staff time, with supplies, with other costs that go into whatever activity you're doing. It's really common for us as program managers at OSAP to hear, oh my goodness, I forgot to include my evaluator invoice, or I got employee salary, but I didn't include benefits. So even having something, if you're not accustomed to billing, that reminds you of all of the different places that you have to pull together to do billing. So that moves into the next bullet of documenting how you determined those costs. So where did you find all those pieces? Is there somebody that you have to talk to every single month to get that, other than salary, that gets all of the receipts or the things that you actually purchased? Being able to have a plan or a checklist that covers how you made those calculations. And then the part that I haven't seen a lot of lately, in some respects, is how you take what you generated, like a general ledger for the month, into how do you enter that into star billing. So I'm not seeing all of the calculations that go into, we thought that this much was community-based process, or this much was information dissemination, and how you do those different portions. And of course, the way that the STAR system is set up is that you have 30 days from the end of the month to enter whatever that month is. So we're currently in August, you have until the end of September to enter August billing. Right, so now this is looping back to what I already thought this slide was earlier. The reason it's really important that every person has their own STAR account and you're not using somebody else's is that every time you use STAR, you're affirming that the costs you enter are accurate and that you have documentation for all of those costs, which is part of the reason why we want you to add, to attach a lot of supporting documentation that demonstrates those things, because not the fraud, waste, and abuse it should be forefront in all of our minds, because we are lucky enough to receive a significant amount of funding. Granted, there's never enough money for prevention, but we still get a pretty good chunk of money, and we want to use it as effectively as possible. We want to ensure that we're not engaging in any waste or abuse, and that we have the supporting documentation that proves that we're doing a good job. I would recommend, as far as a redundancy piece, is that you have one person that puts everything in STAR, and then a new fresh pair of eyes, ideally a senior person, like a program coordinator that enters it, and a program director that reviews it. Makes sure that you're including the benefits or the evaluator invoice, or someone who's who's more in the financial area of your organization, who can at least make sure that the amount of the invoice is what the total is matches what they have for the monthly ledger, so that something is not falling through the cracks. But in having at least 2 or 3 people look at it, I do want to reiterate that for a lot of the grants, there is a requirement that you designate at least 2 people to handle your billing and within STAR. And that's also so that if somebody is unable to enter billing for whatever reason, somebody else knows how to do it, so that you're not putting in jeopardy being able to recoup your expenses for that month. So moving on into contractual items. Most, if not all, of our contracts are cost reimbursement, and that's due to the state law about payment for purchases. You're more than welcome to look up the state statutes. It requires that we structure our subcontracts to accommodate cost reimbursement, meaning you have to pay for it before you bill us for it. And then, of course, there are a couple exceptions, because that's the nature of our world, I suppose, with complexities, that you don't buy the, you can't look at the magazine before you purchase it. You can't use you have to purchase airline tickets before you actually go. Whereas normally we want the programmatic activity to happen first. So there are a handful of exceptions.
Hey, Heather, do you want to save the questions for the end, or can I?
Sure.
Yeah, real quick.
Go ahead.
Okay. So there's a question that says, Heather, do you want more than the time report with the explanations, like what we submit at mid-year and final reporting throughout the year?
Hold on. I guess I need to read it. The time report. So that means like the breakdown of what individuals are doing, but
by strategy.
I don't think we do that at the mid-year and final report, though. We do have a summary of your whole budget,
And,
Um,
and I think that's what she's asking. Do you want more explanations in those time reports?
if you're including time reports on what you're doing for different strategies, that's fabulous. I wouldn't say that's what is in the mid-year or the final year reporting, because we don't ask about how much money is spent on different strategies. So I feel like they're different things. But it sounds like if you're doing a time report that includes, I spent this much time on this strategy, that certainly speaks to what I was saying. And if I didn't answer your question, by all means, feel free to email me and we can chat about it.
Yeah, and I can ask if we can add that at the end, if we could possibly unmute them. Okay, thanks, Heather.
Absolutely. Supporting documentation each billing cycle. If a billing cycle is every month, absolutely. We want to tag what it is that you are, when you are doing an invoice, you are asking for reimbursement for what you've already spent, and attaching your supporting documentation to each invoice in STAR is ideal. It allows us not to have to track you down specifically if, for example, the feds audit us and our system. It also demonstrates to me that you guys are on top of your game, that you guys are definitely ensuring that you have the supporting documentation and you don't have to scramble to try and find it. Okay, so covered cost reimbursement. Dates. Okay, there's a couple of different ways of thinking about cost reimbursement and actual dates. Of course, billing has to be entered and on a specific invoice within 30 days after the end of the month, which we already covered. But if you're not very fiscally minded, I would encourage you to literally not bill us until you've paid for it, and then include the date you paid for it. That makes it really clear that you're entering the actual date or the date range that something happened, not that everything happened on the first of the month, which, as a sidebar, the smaller little dot there is that it helps when you get that long list of pending items in STAR and they all say community-based process or environmental. Being able to use different dates is a nice way for me, at least, to cross-reference your supporting documentation and when a cost might have occurred to what's actually in STAR, to ensure not only is the total correct, but that what you're entering seems to correlate as well. Of course, the end of the year makes things a little more complicated. And if you are not fiscally minded, I want you to think about it more like at, well, that's not really the end of the year. You still might have your evaluator invoice for June. Everybody's doing a mad rush to write the final report, but that might be the one exception to use the date you paid for it, because you're going to pay for your evaluator probably after the fiscal year is ended. It's not ideal. And you really need to make sure that you've paid for it before you bill us. But that's the mad scramble at the end of the year. And if that didn't make sense to you, again, I welcome to walk through this with you when I have a little more time. But in general, if you use the date you actually paid for something, say you had a July 30th event with a paid speaker, the speaker's invoice doesn't show up until August, so you pay it on August 15th. And then you'll be entering all of your August billing in September. So you enter it in STAR by the end of September, and it was an August 15th expense because that's when you paid for it. Okay. The last piece, I think, on the contractual area is that costs have to stay within the same fiscal year. So you get a contract for $100,000. That has to be spent between July 1st and June 30th. After June 30th, that money is gone. So there at the bottom, the funds must be spent during the fiscal year. Any unspent amount expires, it disappears, it's no longer available. So what's worth, like normally we're talking end of the year stuff. Typically what I've seen lately is that our financial director wants things as early as humanly possible so that we can close our own state fiscal year books. So ideally it's July 7th, but the last possible chance is the typical end of the month following, so July 31st. Okay, moving on to allowable and unallowables. There should have been a page in all of your scopes of work this year that called out more explicitly than we've really done in the past, things that are allowable and the things that are not allowable. Your finance staff may be surprised to learn that we do allow food up to $3 person per day. But if it's integral to the meeting, to the success of a meeting, that food brings the community together. There's no way around that. The use of small non-cash incentives for data collection is something that we allow, and we are allowing people to have Zoom accounts, to subscribe to Dropbox or Basecamp, or have Office Suite, things of that nature. Unallowables, we can't do sterile needles or syringes, we can't do furniture, we can't do promotional items. That one's explicitly from SAMHSA. It's under Appendix H if you're curious at all. We can't pay for law enforcement time, or we can't pay people to participate in our prevention services, and we can't allow computer software, computer related equipment. And lastly, this one's new, we can't allow any one person's salary to be above $95.81 an hour. Okay, bundling. So this goes back to STAR data. I completely get that there's a lot of information that we ask, but it makes life a little easier and more efficient to be concise, to try and bundle things together. But that actually doesn't give us as good of data. And when I'm cross-referencing what your supporting documentation is, I need to be able to say this person's salary was this, and I see an item for that amount. I want it to be more clear in the line items, what is associated with what within your supporting documentation. It does add more work, certainly on your end, but that allows for whomever is coming in to do an audit to be much more explicit about like, oh, cool, this absolutely relates to this, that like it's very clear. There isn't a gray area where you've got $1,000 or $1,500 and it's all of these things put together, where if you didn't write that down about what goes into that cost, that may be lost for forever. And it may be hard to try and recreate what you were thinking when you put different costs together in the first place. So I would encourage you to err on the side of caution, to add a lot of items within STAR, and just be more explicit in what those individual costs are. Similarly, and this is also particularly for PFS 20s, as you move away from the SPIF process and into implementation here very shortly, people find it easier to bill to the SPIF process. And I'm sorry, discretionary grants, this doesn't pertain to, as opposed to strategies when you're in implementation. It makes a lot of sense, and it seems much easier to just assign a cost if it doesn't really fit anywhere specifically as a staff meeting, to bill it to capacity. But then your capacity gets larger and larger, and when we get to implementation, we'll be funding and contracting with you specifically to implement strategies. So we want the costs to reflect what's actually happening in your organization. So we don't want it to look like you're doing more work on the SPIF process when really you are doing work on strategies. It's just sort of awkward to figure out how you want to pin it to a certain strategy. Plus, we get better data on the back end about how much different strategies cost. And on that note, it's perfectly okay if you're not spending the same exact amount of money or time on every single strategy. It makes sense that some strategies take more time, others take less, especially some take more money than others. If you've got a media strategy, you know exactly what I'm talking about. But we want you to be accurate in what you're reporting because we get that data on the back end. And it's really useful for us to know media strategies cost more. Or there's more time and effort and staff man hours involved in one particular strategy over another. So what this means is if you're buying supplies and it's not specifically for one type strategy, and you're actually just buying it for all of the strategies you have, it makes sense to divide that cost across the strategies. So if you spent $240 on supplies, you have 6 strategies, that's $40 a strategy. So you'd be entering that item when you purchase $240 worth of stuff. And in STAR, you would say, yes, every strategy, and 6 goes into 116.66%. I guess one of them would be 6.7. But at any rate, there'd be a division that would represent, let's see. Yeah, it's definitely, Christine says sometimes it's hard to break down your day by activity, but I get it now. Thanks, I'm glad to hear that. Yeah, it's also, I can expound obviously for way longer on what we get on the back end and how that it feeds reports that we have to give to SAMHSA. Okay, I've got 6 minutes and I'm actually doing pretty good. Okay, so how to document costs. You need 3 things. So as you're putting your supporting documentation together, if you can achieve these 3 objectives, you will be in the clear. And the first is what I've already referenced, how you calculated the total cost for what you're doing. Staff time, supplies, if you had speakers, if you had time, a cleanup, if you had incentives, what are everything that's included and how did you come to those figures, and how did you decide what CSAP 6 it was, or what were all of those calculations? The second is that the things you are charging for existed, because unfortunately there are people in this world who will pretend and make up costs, and if they don't, this proves that what you're doing actually took place. It's what I'm seeing missing in a handful of supporting documentation is you're not including, well, we'll get into it. I have another slide on what that looks like. So let me go to the third one, that the costs that you are including here, not only that they took place and that this is how you calculated them, but that they are necessary and reasonable. And there's some, there's a methodology in documentation on how you can demonstrate that. Okay, so proof that something took place. Sign-in sheets, minutes, notes from a meeting, agendas, copies of emails if you had to go somewhere, including your evaluator invoices. If you had a vehicle log and you were doing travel, not really this, suppose that bullet didn't really age very well right now, but in theory, and then trainings, including the fact that you have an email train about a Kamama course that you were taking, or you have a certificate from a course that you were taking online that helps support your staff breakdown of like, yeah, I spent 6 hours today working on this training, and here's my proof that I completed it. Those are little things that don't seem directly related to, yes, in fact, these are the costs and these are how I calculated it, but it's important that we have proof that the activity actually happened. Examples that costs are necessary and reasonable. So including pay stubs, you don't have to do that every time, but regularly, one copy per pay period is great. If you have a receipt when you purchase something, oh, that is gold. And if you didn't already know that, it is absolutely gold. Please have several copies of those and include that in your supporting documentation. And then a worksheet if there were multiple things, and how you, some sort of written explanation of them. Oh, I added a 0, so ignore that. So my example here, okay, managing time. is that if you have a flat amount for a contractor, you must be able to provide a breakdown. And this one I got straight from the feds. You need a breakdown containing the hourly rate and the number of budgeted hours and like what you intend to be doing for that, for those hours. And that's not something that we've required before, but it is sort of setting the standard that the feds want to see. So if you are engaging with a particular group and you want their assistance and participation, it can't just be like, oh yeah, they're going to help us out and they're going to do that for X amount of dollars. There needs to be more language around why is that necessary and how is this a reasonable cost for what you're doing, which demonstrates like what you're getting in return for that money. Okay, last two. So I'm repeating myself now here a little bit, is that it's really good to have at least one financial person involved to help triple check that what you're billing for is everything that's in the monthly ledger. There should not be like a conflict or a difference between how your organization's finances occur and what it should look like in STAR, in your billing and documentation for OSAP. If there is, that should certainly be something your program manager is aware of and understands what's happening there. And then the lottery contingency. It's really good that you have how you bring all of those costs together, where you have to go and who you have to talk to, and how do you calculate how you enter things in STAR and decide which CSAP 6 it is, or how you break out staff time for different strategies, because staff turnover is inevitable. And I like to think that's because we're all going to win the lottery and we're going to marry rich and retire young. And someone has to come behind us to continue the valuable work that we're doing. So you want to set up your methodology so that somebody who is unfamiliar can step into your place and at least follow your template and to be able to bill in STAR and how to document. And that's my long and the short. And I'm sorry that I did my usual spoke way too quickly, too fast. But again, please don't hesitate to reach out to me. I completely understand that there are a wide variety of abilities, and I want to be able to help you do the best job possible in a way that protects all of us and demonstrates that we're doing really good work for the money that is entrusted to us. So thank you all for your time. And do we have time for questions, Tone, or shall I just encourage them to reach out to me?
I think we can get questions maybe at the end if that's okay. We definitely want to give folks a break, give a short break, and then we will come back here. Let's see, what time do we need to come back? Before 2:55, the timer will be on. So thank you so much. Thank you, Heather. I appreciate your expertise in this area. So thank you. All right, we'll take a break. Hi, everyone. I'm just peeking in. I just want to let you know that when the timer goes off, we would love to do a poll with all of you. And so be on the lookout for the question and then we'll get rolling. So we've got a few minutes, but just want to give you a heads up. Thanks so much. Thanks, Bernie. Yeah, we just saw the email as well for New Mexico governor reinstated mask mandate for indoors. And all the presentations will be sent out at the end, I believe at the end of today. And if not, we will probably be sending them out tomorrow. And also they will be posted on the New Mexico Prevention website. So you'll have opportunities to download if they're not emailed directly to you. So just make sure we have your email, make sure we're aware. I don't. It probably is too late. Okay, sorry. I do want to, if we can pull up the poll as we're bringing in our other presenters. So I wanted to do the poll for the, how many of you have received training on opioid overdose recognition and response? So if you can fill out that poll, that'd be great. Wow, okay. We have quite a few, and then we also have a few that haven't. So great, thank you. This is good information. I appreciate you taking this quick poll. So welcome back, everyone. Woo. Do a little stretch. We're almost done. We're almost there, all right? Our final presentation. This is one of our long-term partners from the New Mexico Department of Health. New Mexico DOH has been such a wonderful and reliable partner. We are so thankful for their continued support. We also want to acknowledge how busy this past year has been for them as they were pulled to responsibilities related to the pandemic. Thank you for your work to respond to COVID-19 and for your continued support for OSAP and OSAP programs. We know that there's, so much happening and so much going on. So we appreciate you, especially attending today. Today, we're going to hear from Alicia Campbell, Annalise Mayette, Haley Peterson, Megan, I don't want to say her name wrong.
Dysinger.
Dysinger, thank you so much. And Josh. We have Josh. Is it Josh or Joshua? Okay.
Josh Swatek. Yeah.
Okay, Josh. Thank you. From the Substance Use Epidemiological Section and Harm Reduction Services. The main focus of the presentation will be to provide OSAP providers with substance use indicator trends, including preliminary 2020 data that you can use to guide your work. Putting a presentation together like this takes numerous data sources, coupled with the effort from many members of their section to perform data analysis, slide construction, review, editing, and approval. We greatly appreciate all of the work that went into creating this presentation and look forward to seeing it. Over to you all. Thank you.
Hi, everyone. I'm Alicia Campbell. I am going to introduce, starting out with this is the substance use epidemiology section and harm reduction services at DOH. We've come together to provide you with some substance use trends in New Mexico, including as much 2020 data available, given the delayed final reporting with some of these indicators. Several of us will be presenting today, and we hope you can enjoy the presentation. We would like for all the questions to be held until the end so we can get through, and we're going to start with Haley. So Haley.
Hi, everyone. I'm Haley Peterson. Jesse, do we have the slides up? Great, perfect. Let me minimize all these videos going on here. All right, so if we could go to the next slide. Again, I'm Haley Peterson. So I'm the drug overdose morbidity epidemiologist with the substance use epidemiology section. I'm going to first start out with our emergency department syndromic surveillance data today. But before we jump into that, I think as we're talking about the data trends today, there's just a few things we should all keep in mind as we think about it. So of course, I think a lot of people are thinking of, how did the pandemic impact these trends? But there's still so much to consider of how different confounders may be impacting these trends that we're seeing. So of course, when we're talking about a pandemic, there could be hesitancy to access healthcare services due to an infectious disease going around. And so, maybe being a little bit fearful of going to the hospital or accessing medical care during that time. But on the flip side, there could also be hesitancy to access services due to economic hardship caused by the pandemic. Even if someone was able to maintain their health insurance, I think it's certainly possible there could still be concerns about paying for any out-of-pocket costs that could be associated with medical care. And then we also have a confounder of the increasing presence of fentanyl in New Mexico. So there's just a lot of things to consider that I think, to me personally anyway, makes it difficult to make any conclusions at this time until we continue to look at the trends, after 2020, 2021 and beyond. So I think there's still a lot for us to look at and evaluate as we look at all these data. So if we could go to the next slide, we'll get started on our emergency department data. So the emergency department syndromic surveillance data specifically was originally intended for infectious disease surveillance. In recent years, it's been utilized to monitor ED visits related to other conditions, and that includes non-fatal drug overdose. The reason we've started to use this data for other reasons is that it has the advantage of providing more timely data. So I receive this data on a quarterly basis, usually a month or two after the quarter ends. So that's a bit more timely than other sources of data that we have where, it takes several months after the year ends for the data to be finalized and closed out and get to us and be analyzed and all of that. So this has the advantage of letting us look a little bit at more recent data than some of our other data sets. But there's important caveats to consider when we look at this data. The stability in the number of hospitals reporting to the data set changes over time. It's really only been stable in the last maybe 2 years or so. The syndromic surveillance data does not include federal facilities like the VA or IHS facilities. These data are also intended to provide a rough estimate of disease burden rather than an exact measure. So that's something to keep in mind. And then for these ED visits, toxicology is not consistently performed. So some folks, may have like a urine drug analysis or something while they're there for a visit, but other folks, the diagnosis may be based on naloxone working. So then, it likely was an opioid overdose, or perhaps it's based on sort of self-report of what the person had been using. So it's important to note that it might not be as strictly accurate based on substance as maybe our death data is, for example. So we can go to the next slide. So this slide is just showing you the number of hospitals reporting into the emergency department syndromic surveillance system over time. So We start at the first quarter of 2016 on this graph and end with the first quarter of 2021. So as I mentioned before, when we look at the second half of 2019 is when we really start to see more stability in the number of facilities reporting. So that means that prior to that second half of 2019, we were, unfortunately missing some data there. So that's something to keep in mind as we look at the next slide. So this graph is showing you the total emergency department visits by month. So this is for any cause. So that could be, flu or COVID or drug overdose or an alcohol related call. This is all causes from July of 2016 through March of 2021. Again, that blue vertical line is showing you sort of where we have some stability in the number of facilities reporting in. So that's why you see an increase there starting in the second half of 2019. But we do see a significant dip in the total number of emergency department visits in April of 2020. So that was, of course, right after our lockdown began in New Mexico, so could indicate, some impacts there due to, healthcare access at that time. Next slide. So this slide will show you the total drug overdose related ED visits for the same time period. And what we're talking about here is overdose visits related to opioids, amphetamines, benzodiazepines, or cocaine. And again, this is based on finding the ICD code in the diagnosis field. It's not necessarily based on toxicology. Though of course, if they did do toxicology, that may have informed their diagnosis. So again, we sort of see an increase in the fall of 2019, but then it returns to what seems like a stable rate in early 2020. Our peak in the total number of ED visits is in July of 2020, actually. So that's sort of interesting. And then at the end here in March 2021, we're seeing an increase, but it's important to note that, we may see the data sort of change as we get more data over 2021. So we'll have to see if that's a trend that continues or if that was sort of just due to the recency of the data when it was analyzed. Next slide. And then this slide is a rate per 10,000 visits. So this is to sort of stabilize for the fact that we didn't have all the facilities reporting in. So it's a rate per 10,000 ED visits. So the number of drug overdose related visits over the total number of ED visits. So it's pretty relatively stable over time. And our peak here, of course, is going to be in April of 2020. And the reason that happens is, of course, our denominator, which is the total number of ED visits, saw such a stark decline in April of 2020 that because our rate of drug overdose ED visits stayed the same, that means we see a large increase in the rate there. So again, I think it's important for us to just continue to watch how these trends may change going into data further into 2021 to see if that blip at the end there in March 2021 will hold steady and or continue increasing. All right, and then next slide. So our partners at the Emergency Medical Systems Bureau were kind enough to create some slides for us using the EMS data. Madison Schaefer actually created these slides, so if there's any questions about them, I'm certainly happy to connect you, and I will do my best to convey what these slides have today. So next slide. So when we're talking about EMS data for syndromic surveillance, we're talking about like ambulance calls. And one advantage is that they have significant coverage of rural and frontier areas. Because of course this is statewide. They have all of their different ambulance services all around the state reporting in. So that can be really helpful. For other states that don't have their ED data, EMS data can be also really useful because that may be all they have access to. We're fortunate in New Mexico that we have both. The EMS data has the advantage of a really quick turnaround time. So that is something that maybe could be utilized for even quicker turnaround on viewing trends like this. And then a huge advantage here is that it captures encounters that would not be picked up in some of our other healthcare system data sets. So say somebody calls the ambulance but refuses transport, due to any sort of reason, they would still be in this data set, which can be really useful for conditions like substance use disorders or mental health problems. Next slide. There are limitations, of course, as there are with any data set, but this does have a smaller sample size than the emergency department data. It's also biased, of course, to the sickest patients. So if someone's calling 911, it's probably a much more severe situation than a person that can, drive themselves to the emergency department, or, have a friend that can drive them. Maybe it's not quite as emergent as someone calling 911. There's also a lack of diagnosis in the EMS data, so it's really more based on their impression at the time. It's not truly a clinical diagnosis with the ICD codes and all that. And then there's COVID-specific limitations. When we're looking at the more recent years of data, there was certainly impacts due to the sheer volume of COVID-related calls. So when we're looking at some of the percentages in calls, there's going to be a huge impact just due to the amount of COVID calls that occurred. Next slide. So with this slide, I'll orient you to how these slides are laid out. So this is the total number of EMS activations for New Mexico for 2019 to 2021. So at the bottom, if you look, it's from January to December there. And then our yellow line on the graph is for 2019 data. The orange line is for 2020 data. And the sort of grayish, greenish line is for the first half of 2021 data. So they're put here like this so that you can see a comparison of the years to each other. And again, here we see in April of 2020, the orange line, we see a dip there in the number of total EMS activations, which somewhat matches what we saw in the emergency department data that perhaps not as many people were wanting to access healthcare services at that time for a variety of reasons. We see it return to a relatively normal, but maybe slightly increased number of calls in the summer of 2020. And then we also see sort of an increased number of calls in winter of 2020. Again, this is total. So it may be, influenced by the sheer volume of COVID-related cases at the end there of 2020 on that orange line. Next slide. Here are alcohol-related calls. So when we're looking at the EMS data for the runs related to alcohol, again, we see a dip in April of 2020 on that orange line. So that appears to be a trend that's holding steady through all these different conditions. But we do see it sort of follow normal trends if we're considering 2019 maybe a more normal year for this data. We do see a slight decrease at the end of 2020 for alcohol-related calls. So that could be, due to a variety of reasons. And in 2021, we seem to see an increase in the number of calls starting in the spring of 2021. So we'll have to see how that trend continues going forward. And next slide. This graph is alcohol-related calls again, but the percentage of calls. So again, the influenced by, especially when we're looking at that winter of 2020, which is the end there on the orange line, it makes it seem like there's a huge decrease, but influenced by the sheer calls. So, so I'm not sure that you can rely on that percentage there to show that it's really normal at the end of the year there. Next slide. So this graph is a little bit different. This is showing us the opioid use. Oh, sorry, Jesse, I see your message says my mic is cutting in and out. Is this better? I'll get closer to the camera. So on this graph, it's opioid use and overdose calls for the same time period, but this time they've laid it all out as one trend line from January of 2019 to June of 2021. So we again see a dip in the number of calls in April of 2020 with sort of a return to maybe a slightly increased number of calls in the summer of 2020. But then we're again seeing an increase in the number of calls sort of in the spring of 2020. So that may match what we saw in the data starting in March of 2021. I also know that some of our partners in our EPI section noted, they've been noting in recent months a large increase in the number of overdose reports they're getting from some of our hospitals that are using drug overdose as a reportable condition for us. So that is a concerning trend that, again, I think we're going to need to watch for the rest of 2021, and continue to push all the interventions that you all work on so well with our various prevention programs and naloxone distribution and all that. Next slide. This is, again, looking at the percentage. So when we're seeing that dip towards the end of 2020, the winter months, I think it's important to keep in mind that the number of COVID calls may be impacting this percentage here, but we do start to see an increasing trend towards the middle of 2021 again. So just, again, we'll have to continue to watch these trends over time. And I think if we go to the next slide, I'll be handing it off to Annalise. Thank you all.
Hi, I'm Annalise Maya, and I'll be sharing a few slides on alcohol death. Just before we start, a couple of quick reminders. When we talk about drug overdose death, we're talking about deaths that are caused by or due to drug poisoning. When we talk about alcohol death, we're talking about alcohol-related or alcohol attributable deaths, and that's based on the CDC's ARDI, which estimates the attribution of alcohol for other causes of death. So this is an estimate, whereas drug poisoning deaths would be an exact count. The other point for this presentation is that the 2020 data is preliminary, and so it may change. In fact, it will change, right? It's preliminary. It could go up, which is somewhat obvious, but counterintuitively, it could also go down slightly when all of the causes of death are fully established and the record is closed. Next slide, please. This slide shows you final 2019 data, which has been shared previously, and preliminary 2020 data. So it's not directly comparable, but it's the closest we have for comparison. You can see the total alcohol-related death, and this is counts, not rates. We usually bring rates, but these are counts for 2019 and for 2020 in the tall blue bars. And you can see that the counts for 2020 are higher than the counts for 2019. If you look at the orange bars, those look about the same. And in fact, I can tell you that from looking at the numbers, 2020 is actually fewer than 10 higher than 2019, the 2020 preliminary. If you're wondering why I didn't put numbers on there, it's not because I want to know something you don't. It's because I feel like putting the numbers on makes it feel kind of more real, more final. And also I know that probably about a quarter of you would see those numbers and just remember that number for 2020. And as I said, it will end up changing. But you can see that the gray bars is where the big increase is appearing in this preliminary 2020 data. And that's the chronic cause. So alcohol-related death due to chronic causes. And chronic causes are things like chronic liver disease, which those of you who've heard us talk, even myself or previous alcohol epis talk, you know that that accounts for about a third of the total alcohol-related deaths in New Mexico. That orange bar is acute or injury-related death. Next slide, please. So this is just that count. Again, it's not a rate of alcohol-related death in New Mexico. And you can see that from about 2015 to 2017, our count was increasing slowly. That's bad, but at least it was increasing fairly slowly. From 2017 to 2019, it started increasing somewhat more rapidly. In other words, the number was going up more quickly from year to year. And from 2019 to this preliminary 2020, it's increasing even more rapidly. Most of you probably know that New Mexico has the highest alcohol-related death rate in the US. Obviously, we don't have the highest death count because there's only 2 million people in our state, but we have the highest alcohol-related death rate. And also our rates are increasing. So we're at the worst point, and we're the worst, the state with the worst rate, and it's getting even worse. So things are really going in the wrong direction. Next slide, please. But there are things we can do about it. The Community Preventive Services Task Force recommends these different strategies. And most of you have heard me talk about this before: electronic screening and brief intervention, or in general, screening and brief intervention, which is also recommended by the US Preventive Services Task Force. It's a really powerful tool. The Community Preventive Services Task Force also recommends increasing alcohol taxes, increasing dram shop liability. Dram shop is just this kind of Renaissance term, 16th century term for an alcohol outlet. And as happens sometimes, these archaic terms get codified into law and they stick around. So dram shop liability. And then maintaining hours and days of sales, regulating alcohol outlet density, and enhancing enforcement of laws prohibiting sales to minors. And, in New Mexico, we also have some pretty strong laws prohibiting sales to people who are already intoxicated. Next slide, please. Some things that DOH is doing is we disseminate data on the counts, rates, and harms of excessive alcohol consumption. We collect and analyze Medicaid paid alcohol screening and brief intervention services data. This is a proxy for provision of service in New Mexico. We are actually proposing to add the alcohol screening module to the BRFIS for the 2022 survey. So fingers crossed that'll be in. There is a whole process, and we do not know yet if that will be approved, but we're trying. Also, our previous state epidemiologist, Dr. Mike Landon, called a quarterly statewide interagency work group to address alcohol-related death in New Mexico. There are many agencies who attend, and that quarterly meeting continues now. And on Zoom. Once, of course, with COVID, we couldn't continue to meet in person. We also support local evidence-based interventions and programs such as what you do. So thank you so much. Next slide. I am done. If you have any questions about any of that, please feel free to reach out to me. We can call, we can Skype, we can figure out some way to discuss any questions or data requests you have. Thanks so much.
Cool, thanks, Annalise. I guess I'll take over. My name is Megan Deisinger. I'm the drug overdose epi with the New Mexico Department of Health. And I'll also be sharing some provisional or preliminary 2020 drug overdose and polysubstance data with you all. I'll echo my colleagues in saying that these data are provisional or incomplete. I'm still waiting for the 2020 death file to be closed by Vital Records. We get a little closer every month, but for now, the data are provisional, and what I'll mostly be sharing are counts, no rates today, kind of for the same reasons that Annalise stated. So we can get started with the next slide, please. Oh, right. So I have more caveats, I guess. So yeah, these data are provisional as of last month, July, middle of last month. They're subject to change. They will change. Unfortunately, in my case, the numbers probably are only going to go up. So we can expect the numbers to change and to increase. The biggest takeaway for 2020 is going to be that it will be a record number of overdose deaths for New Mexico. The count will be greater than 750, probably closer to 800. I don't know how close to 800 yet. This increase is being driven primarily by the illicits that we see in drug overdose deaths. So fentanyl, methamphetamine, cocaine. Not seeing as many deaths due to heroin these days. And while this next bullet says the overdose death the death rate due to prescription opioids is decreasing, I believe that will be amended when the data are finalized to say that the death rate due to prescription opioids is flat, probably not decreasing. We're also seeing an overall increase that's being in the statewide count and rate that's being driven by increases in the urban and high population counties, Bernalillo, Doña Ana, Santa Fe, San Juan, and also by increases in the Southeast region. Again, I'll know more about kind of what's happening across the state once the data are more final. Next slide, please. And I just wanted to say also that unfortunately, kind of the increases that we're seeing in New Mexico are happening across the country as well. So this little chart or graph is an estimated percent change, or is the percent change in number of overdose deaths by state. Yeah, this will be estimated from 2019 to 2020. This comes from the provisional NCHS data, or National Center for Health Statistics. And we can all see there's increases basically everywhere except maybe for South Dakota. Next. And then just to refresh our memories, these were the estimated drug overdose death rates by state for 2019. I think most states have finalized their 2019 data, but there may still be a few outliers, which is why this says estimated still. Some of you may remember that in New Mexico, our overdose death rate for 2019 was 30.4 per 100,000, which put us at number 12 in the United States for drug overdose death. And the next slide will show the provisional estimates for the drug overdose death rates by state for 2020. So we can see that there are big increases happening really across the country. Unfortunately, in the Southwest, it looks like New Mexico and Arizona will have the highest overdose death rates. And then we also are going to see high rates in the Northeast and the Mid-Atlantic and Louisiana. Next. So this is a chart that I produce kind of on a monthly basis to sort of keep track of how final the death data are for each year. So many of you have probably seen this chart before. It's a little bit busy, but basically what it's depicting are year by year how the 12-month running totals of overdose deaths by drug class are changing month to month and year to year. So the highlighted portion in blue is actually the percent change from December 2019 to December 2020. And really the takeaways here are that we're seeing an overall increase in drug overdose death. But again, what's driving it are particular substances. So this scary red line is our fentanyl and analogs drug class, which is up 130% for the 12-month period between December 2019 and December 2020. So fentanyl is a huge problem. We've got to figure out what to do about it and other illicits. I don't want to ignore methamphetamine, which is our green line. Deaths due to meth are still up, and methamphetamine is still the #1 driver of drug overdose death in New Mexico. As we get closer to closing the death file, that may change. It could be nearly a 50-50 split between meth and fentanyl. We'll just kind of have to see how it shakes out. Another kind of area of concern is the recent increase in deaths involving cocaine. Those are up almost 50% for that same 12-month period. And everything else is pretty stable. Don't be fooled by the -4, which is meant to go with the brown line for heroin. I think we're going to see that deaths involving heroin will probably, there will be no change rather than a decrease. That's likely true for benzodiazepines as well. And our non-fentanyl prescription opioid line in purple is unfortunately depicting a little bit of an increase, and we'll just kind of have to see what happens with that kind of into 2021 and into the future. You know, one warning is that looking at these percent change, the 12-month period, those don't necessarily indicate a trend, but when we look at it with the prior years included, that gives us a better idea of what's happening long term. I think that's it for this slide. Next slide, please. Okay, so here's counts of the top 10 drugs involved in drug overdose deaths in the provisional 2020 data. As always, these substances are not mutually exclusive. I should have said that in during the last, the display of the last chart as well. So we wouldn't want to add all these numbers up for a total number of drug overdose deaths, because often drug overdose deaths will involve multiple substances. But basically, I just wanted folks to see, you know, what are the substances most commonly involved, and they include methamphetamine, fentanyl, heroin, alcohol, cocaine, methadone, oxycodone, alprazolam, hydrocodone, and codeine. And again, we'll see what that split looks like between methamphetamine and fentanyl, and in a matter of weeks or months, we'll see how long it takes. Next. Okay, so this is a different type of chart than I think many of you have seen come from the Department of Health before. So there's going to be a little series kind of highlighting some of the polysubstance use that we're seeing in the provisional 2020 death data. And so the way that we'll read this, so each chart will be for a different drug or drug class. And then what we'll want to do is, if you look in the cell in the top left-hand corner, there'll be that substance by itself. So we see for 2020, we see that heroin, so for 2020, the heroin involved drug overdose deaths are frequently only include heroin, or they include heroin and methamphetamine. So that would be the top combination with one other substance would be heroin and methamphetamine. And then if you want to know what's going on with heroin and methamphetamine plus another substance, we would look down and to the right. I hope I'm explaining this well enough. This is a new one for me to try to explain also. So, and again, these numbers are going to change, so we don't want to get too focused on these individual counts here. But basically, the point is that for deaths involving heroin, we most often see them in combination with methamphetamine and with methamphetamine and fentanyl. So it's either heroin by itself, heroin plus meth, or heroin plus meth and fentanyl. And then that's how we read this. And then I also included the percent where alcohol is involved on the far right-hand side. So you can see, you know, where alcohol fits in with these as well. So I believe the next one is methamphetamine. Let's take a look at that one. Yes, thank you. And so we can see that for the deaths involving methamphetamine for 2020, they look a little bit different. Methamphetamine or deaths involving methamphetamine most commonly occur with methamphetamine alone. Again, this is based on the provisional 2020 data. This will change. This chart could look different in a week or a month. But so we see for meth, it's usually by itself, sometimes involves heroin, and again, sometimes involves that combination of heroin and fentanyl. And Jesse just made a good comment Yeah, saying it just, I saw it flash and then move, but the dark red would be the more primary involvement, and then the lighter red would be like more secondary or tertiary. So that's a good observation. Thanks, Jesse. Next slide. So same kind of chart, but these are fentanyl involved drug overdose deaths for the provisional 2020 death data. Here we see it's a little bit of a different pattern. So we're seeing that fentanyl looks like it's most commonly seen by itself, but it's also seen often with heroin plus methamphetamine. It's also seen with, so just fentanyl and methamphetamine often, and interestingly, just fentanyl and cocaine pretty often. And then we do see it involved with just heroin sometimes, but it looks like most frequently it's seen alone or in combination with methamphetamine or in combination with cocaine or in combination with heroin and methamphetamine. So I hope as we're looking through these, they're becoming easier to interpret. Like I said, it's kind of a different visualization that we're testing out. So any feedback will be welcome at the end. Next slide. So here we're looking at what we're now calling pain opioid involved drug overdose deaths. Many of you have probably heard this category referred to previously as non-fentanyl prescription opioids. Again, we're trying to build more and more polysubstance analysis into our analysis of the death data. And so we're just sort of playing with different ways to do that right now. And we're working with adjusting some of the drug categories. But the big takeaway here is that for drug overdose deaths involving pain opioids, we most commonly see that as a drug class that's by itself. We don't see it in combination with other substances as often as with the illicits or compared to the illicits. Next slide. And then finally, we have the provisional data for benzodiazepine involved drug overdose deaths, where we can see that this is kind of in direct contrast to the prior slide, where we almost never see drug overdose deaths where benzodiazepines are the only substance involved. So we see that when we're talking about in combination with just one other substance, they're most frequently involved with fentanyl, and then with heroin and the pain opioids. And then we can see that this is the class that frequently involves multiple substances. So we see that frequently benzodiazepine involved drug overdose deaths include fentanyl plus pain opioids, or heroin plus methamphetamine, or looks like cocaine plus fentanyl. So those would be the kind of most common combinations when looking at the benzodiazepine category. Next slide. Oh, I guess I'm done. I'll anticipate questions about that at the end. And then, like I said, any feedback about the display of those charts will be welcome because it's a new visualization.
Hello, I'm Alicia. I am the substance use epidemiologist at New Mexico Department of Health, and I'm going to talk to you today about naloxone distribution, and I'll talk about some reversals, report reversals that we get as well. So let's go ahead to the next slide. So the first graph here reflects the distribution of naloxone throughout New Mexico since 2015. As you can see, there was a steady increase in distribution through 2019, pretty much doubling each year. And in 2020, there was about a 20% decrease from the previous year. And for 2021 so far, we see a distribution of just under 35 listed, but I just got some recent updates and it was before this approval was done. So it's about 40,000 now that I'm showing for distribution for 2021. So it looks like we're we're building back up. This number includes harm reduction, HSD programs, and Medicaid billed claims. So the numbers will continue to change also because Medicaid, it takes up to 90 days for some of their claims to show. So this number, even for previous quarters, will still kind of increase. But this gives us an idea of where we are so far for 2021. And yeah, let's go to the next slide real quick. So there are 3 sources where we get naloxone distribution data from. So we get them from the Department of Health harm reduction programs, HSD programs, and Medicaid bill claims. We do not have complete data for 2021 Q2 yet, because like I said, that New Mexico, the Medicaid claims they take a while for them all to come in. So those are not complete, but I put Q1 on here just to kind of show the graph, to show quarterly trends. And as we had it, and we did have some unexpected events, obviously, in 2020. So I included 19 to get a better picture of the trend distribution. It is noticeable that there was a decline reported in distribution starting in Q2 for our HSD and harm reduction programs, which I think I've heard a lot of, whenever we're having the quarantines went into effect, and I think there may have been some funding changes for some of the harm reduction services at Department of Health. So we did see that those declined during that initial stage of the shutdowns. Medicaid claims also decreased a bit, but Medicaid claims for naloxone were about double what the other 2 sources were. So they were, if you add those 2, Medicaid was about double. So we also see that Medicaid has been the largest distributing source since Q3 of 2019. It'll be interesting to see what the full 2021 data shows, just to be able to compare it to the previous years, since we really just don't know if it had a lot to do with the pandemic or not. But it looks like Medicaid has been constantly increasing since 2019, which was before the pandemic. So let's go to the next slide. So this one, I did something a little bit different. I know I've shown a lot of this data before, but I did some pie charts. It just provides a better visual of the distribution from each source that we get our data from. And in 2019, the distribution was pretty equal among the 3 sources. But in 2020, Medicaid claims was right above 50%. And so far for 2021, Medicaid claims still have the highest percentage of naloxone distribution. So just wanted to show it like that. I thought that gave a really great visual. Next slide. All right. So with the distribution, I figured I'd take a look at some of the reported reversals also. Reported reversals was steadily increasing with a high reported in 2019. In 2020, there was a decrease of just under 30% of reported reversals. I've looked at the numbers that have been reported so far in 2021. It's probably going to change as the data is collected. But something to think about here is that 95% of the reversals are provided by the harm reduction services. And if we consider that it's really about 30% or less of the distribution information that we get, there has to be, I've been trying to come up with other ways that we can start getting reversal data that occurs in the community, just so we can get a better idea of what is really happening. So hopefully some of that stuff will come to fruition and we'll be able to use some of that in the future. But this does really give us an idea of, what we're looking at, because these, quite frankly, could have been overdose deaths had we not had naloxone available in the community for people to do reversals. Next slide. So this I thought was really interesting. So I put the distribution and the reversals reported. I've already shown you both these graphs, but I thought putting them together was kind of interesting because they look pretty identical. So I think, obviously, what this is showing me is the more that we saturate the community, the more opportunity people have to have naloxone and to have to do reversals. And obviously hopefully for us to get them reported to us also. Next slide. So something I've been looking at lately is the number of doses used when a reversal is reported. I think we spent a lot of time talking about how many actual reversals were completed. So I went back through the data to see if there was something else in there that maybe I could look at. And I thought it was interesting to see that each reported reversal, going back as far as I had gone, still was about 1.9 doses per reversal, successful reversal. So I just thought it was interesting. And I broke it down into quarters starting in 2018 through quarter 2 of 2021 so far. As you can see, there was a peak of reported reversals and doses used in 2019, quarter 2, and this number has been decreasing with a slight increase again in this past quarter of 2021. And I think that's all I have. I think that if you go to the next slide, it's going to Josh now. All right, so I'll turn that over to Josh.
Good afternoon, everyone. Hello, my name is Josh Swatek, and I'm the Hepatitis and Harm Reduction Program Manager in the Public Health Division at the New Mexico Department of Health. Next slide, please. So in FY18, we had about 12,000 program participants in our program. And as you can see there on the left side, our program's grown pretty rapidly. And this is just the syringe services portion. If you'd like, I can answer questions about the harm reduction naloxone distribution as well, but I think that was already covered, so I don't need to get into that too much. Provisional data is showing that we have around 17,000 individuals. I just ran the numbers this morning, and we have over 18,000 individuals enrolled in the hepatitis and harm reduction program, syringe service program. And we also had over 56,000 interactions. So our syringe service program was actually the busiest year we've ever had as far as the number of interactions and the number of folks that we've seen, because most of our sites were open during the pandemic. We did have some decreases in availability that happened primarily due to a lot of our public health staff being out on COVID-related duties such as vaccinations, testing, all that kind of things. The increase is likely due, we're theorizing, to our increased reach. We've initiated things like mail-based syringe service and naloxone distribution. We've had more individuals reach more rural communities, and we've been trying to expand outreach hours with our community partners. Next slide, please. So here's something that a lot of people ask about. I don't think it's the best measure of success, but it's something that goes to show, for folks who might be concerned about the number of syringes that are being left in the community. So in 2018, we had about 9 million syringes. This year, we're going to do around 11 million syringes distributed. And as you can see there on the right, those are collection rates. So that's the percentage of syringes that we get back from individuals. And we hover around in the mid-90s. So that's actually really good. That's really high for a harm reduction program, because you have to realize that there's other places of disposal. Individuals can dispose of them in, depending upon the jurisdiction, in their household trash. They can dispose of them in city drop boxes. And oftentimes some of these are confiscated from folks. So really we're showing, a pretty high collection rate. In 2019, there was a dip, but we had to do some provider training and some policy changes that led to that coming back up. Next slide. I think that's actually it for me. All right. And that's it for my portion.
So we really are grateful that everyone was here, and we wanted to leave some time available for anyone who had any questions.
If you have any questions, you can put it in the Q&A or chat.
looks like we gave a lot of information and that there aren't a lot of questions. I think that this will probably, what's for dinner? I think that this will be probably shared with everyone. And so I have all of our email addresses are listed on that final page. We're obviously available for questions. If there's, any other way that you'd like to communicate with us, just send an email and we will get back to everyone.
Thank you all so much. We really appreciate all the information you shared, all the data. I think it's definitely, I like the differences, the new styles, and it's always a lot to hear about. And I appreciate you taking the time to share with us this information. And I know our providers will probably have questions once they get a chance to have those slides in front of them and look over everything. So thank you so much. I also want to thank all the presenters for who presented today as well. And all the slides should be available on the website nmprevention.org following the meeting. So thank you again. As we're wrapping up, I do have a few things, so please don't leave just yet. Okay, so I have a special announcement before we wrap up, but first, a few details for tomorrow. Please plan to attend day 2 tomorrow. Signer will begin promptly at 8 a.m., followed by topic-specific breakouts in the afternoon at 1 p.m. and at 2:45. An email will be sent following today with information on how to join day 2. All you need to do is sign in with Zoom and select breakouts from there. Please be on the lookout for that email. Any questions on that? 8 a.m. Signer, 1 p.m. and 2:45 afternoon with topic-specific breakouts. And now, I want to take a moment to acknowledge one extraordinary individual who has provided all of us her support and guidance over her entire career in prevention. Karen Chayman has been an expert we turn to, a mentor, a friend throughout her time here at OSAP and as the director. As some of you may know, Karen will be retiring at the end of this year, and we will miss her terribly. We will, a lot of folks are like, really not letting her leave. I don't want her to leave. I'll admit, I don't want her to leave, but I do want her to take care of herself. And that's kind of what I'm in her corner and I support her decision. She has provided wonderful leadership as director of OSAP and fostered collaboration and support for prevention programming across the state. Her leadership will continue to have a lasting impact on prevention in the state of New Mexico, long past her departure, and we will wish her the very best in her retirement. Karen, thank you for the many ways you have supported us, advocated, and just helped us grow and continue, helped us be strong and helped us create this lasting prevention system. Thank you. Thank you so much. You have just made a huge impact in everybody's lives and all throughout the state of New Mexico in prevention. We hope that that we all hold a wonderful place in your heart. And we will cherish you too. We will always think of you. I definitely want to express that, I'm very fortunate to work directly with Karen, and she has just been a tremendous leader to me and to help guide me and help, really show me what prevention means and how we can make a difference across the state of New Mexico. And I'm really thankful. I'm very thankful, and I'm glad I'm able to be the one to share that message with everyone. And I don't know if you have any words to share, Karen, but I would like to give you time if you wish.
Thanks. Yeah. Thanks, Tone. I'm almost speechless here. Thanks so much. I really appreciate that. It's certainly been an honor and a privilege to work with everybody and for the wonderful staff at OSAP and all of our wonderful consultants and providers. I can't tell you how proud I am of all of you and all of the wonderful work that you've done for many, many years. I'm very grateful to have had this job and to be able to do this kind of work. It's really meant a lot to me. And it's meant a lot to me to be able to try to encourage and provide all the services we can, all the funding we can, all the opportunities we possibly can, because our citizens in New Mexico deserve it, and you all deserve the opportunity to do all the great work you've done for so long. So thanks to you all, and it's certainly something I'll never forget, and I'll remember all of you. So like I said, it's been an honor and a privilege. Thank you.
Thank you so much, Karen. And I'm glad that you volunteered me to facilitate this meeting. So that I could share, I could be the one to say the message. But thank you again. Thank you all of you for today, and we're going to continue one more day tomorrow. Thank you again. I'm trying not to cry here. All right, well, everyone have a great day. Thank you so much. If you have any other questions, let us know. We'll be here.